Yeah, hope we are live. Okay, yeah, good evening, namaskar, welcome you all. Myself Dr. Dinesh, and I'm your educator on your favorite app, Unacademy Learning app. So, guys, in this platform, in this YouTube channel, we are discussing some important concepts in pharmacology, and we will have the continuous these classes every Tuesday at 9 p.m. So, this is the episode 1. This is the first episode. In this, we will discuss some concepts. So concepts in pharmacology, and the episode 1 is there. So let's start. Just before starting the concepts, a brief introduction about myself. I am your educator, MBBS MD, with having the experience, clinical experience, as well as having the experience of writing a book. This is my code. This is my code to open the special classes, the free special classes, as well as to get the subscription. So Pharma UA, Pharma Unacademy, so Pharma UA, and this is my Telegram group. You can join this group also, Dr. Dinesh Medical Study Group. So in Unacademy, we offer you the free classes. So to unlock my free classes, you can use my code, that is Pharma UA. After unlocking this class, you can enjoy all the special classes in the Unacademy app. So for that, you have to download the app. I will tell you how to download that. And these are the links for the special classes. Like in this month, in the month of this December, we have the class every Monday at 9 p.m. YouTube classes we are having at on the Tuesday at 9 p.m. and these are on Mondays. So guys, let's start with the first concept, that why the IV infusion of phenytoin sodium is given with normal saline, not with the 5% dextrose solution. So phenytoin sodium, which is the anti-epileptic drug, it is given via IV infusion. It can be used in the intramuscular also, but for status epilepticus we don't use intramuscular, because to achieve the peak level, if you give via intramuscular, it may take around 24 hours. So for status epilepticus we use via IV infusion. So in IV infusion we have to basically mix it with the normal saline, but not with the 5% dextrose. Why we are not mixing it with the dextrose or not diluting it with the dextrose solution? This is one of the important concept, one of the important MCQ also which they are asking. So remember, in phenytoin, if you mix it with dextrose solution, so with dextrose, what happens? When you mix it with the dextrose or any other drug, ideally it should not be mixed with any other drug, right? Not the dextrose, right? So if you mix it, it will form the precipitate, and that is phenytoin acid. So that is the precipitate formation. And because of that, it should not be used in dextrose. Now why normal saline? To use it with normal saline, one, the precipitate formation is not there. The second, when we use phenytoin, with phenytoin there is risk of hypotension. With phenytoin there is risk of hypotension. With phenytoin there is risk of hyperglycemia. With phenytoin there is risk of hyperglycemia. Now you can see the first important concept is this one, that with dextrose the phenytoin acid can precipitate formation, and because of that we should not mix it. But with phenytoin we also have the risk of hypotension. With phenytoin we also have the risk of hyperglycemia. So because there is risk of hypotension, so it is good to give normal saline. And because there is risk of hyperglycemia, we should not use the dextrose. So that is also the secondary reason. But what is the primary reason that it should not be mixed with the dextrose? So the primary reason is this, that is formation of phenytoin acid, right? So this is important. And remember, if you use phenytoin via IV, we should give the phenytoin in the large large veins by the large cannula. Why? Because there is chances of extravasation, and because of the extravasation there is risk of necrosis of that local tissues. That is called as purple glove syndrome. So due to extravasation, there is chances of purple glove syndrome. So necrosis in that particular area, right? So that is also you need to remember in the phenytoin. So IV we are using for status epilepticus, but intramuscular can be used in some conditions, but not for status epilepticus, remember, because you cannot achieve the exact level in the phenytoin in the status epilepticus. It will take around 24 hours. And remember, in phenytoin the therapeutic drug monitoring is very important, so you have to check the phenytoin level during the treatment. ECG monitoring is also required. Next is that ipratropium bromide, not atropine, is used in bronchial asthma. Why? So we use the ipratropium, but we don't use the atropine in bronchial asthma. What is the reason? See, both are anticholinergics. And what is the effect of these anticholinergics in the bronchus? If you talk about the atropine and ipratropium, what is the difference? The difference between ipratropium and atropine is natural alkaloid. Ipratropium is semi-synthetic compound. See, atropine is natural, it is also non-selective. So selectivity is less with the atropine. It means it will not only have the effect on the one tissue, one side, it will have effect on the multiple sides. Ipratropium is semi-synthetic, that is having some selectivity. So selectivity is there with the ipratropium. Now because of this, now we want to use in asthma. In bronchial asthma patient, we want the bronchodilation. In the asthma treatment, we want the bronchodilation. And for bronchodilation, we need to give the muscarinic antagonist or beta 2 agonist. So these drugs are having muscarinic antagonistic property. Now we have the M3 receptor over there. Now if you compare the atropine and ipratropium, both are having the effect on M3 receptor. Both can cause bronchodilation. Both can cause the bronchodilation, but still we are selecting the ipratropium. Why? Because that is more selective for bronchus. That is more selective for airways. If you give atropine, it will cause the bronchodilator effect, but it will also cause dry airways. In airways, it will have the effect on the mucus glands, the glandular secretions. So because of this dry airways, there is risk of dry mucus plug formation. And they are not good in asthmatic patients, in COPD patients. So dry mucus plug formation, that can cause the problem to the asthmatic patients. With ipratropium, they are more selective for this airway dilation. They are having less dryness in the mucosa, less airway dryness. Because of that, they are preferred in the asthmatic patient, right? We don't use the atropine. And ipratropium is faster also. It is faster and shorter. So that is the advantage of ipratropium over the tiotropium. That is why ipratropium used in asthmatic patient. So don't use atropine, it will cause more mucosal dryness instead of bronchodilation. It will cause the bronchodilation, but simultaneously mucosal dryness will be higher, and that is the reason it should not be used. Okay, so this is important. The next is the 10 milligram of morphine and 100 milligram of pethidine produce the equal degree of analgesia. 10 milligram of morphine and 100 milligram of pethidine produce the equal degree of analgesia. This means what? So both are having the equal degree of analgesia. So if you see the effect, if you see the response, that is equal. So suppose this is the dose and this is the response. Very good, Aditya. If you see the morphine and pethidine, the equal degree of analgesia, so you can see the effect is equal degree of analgesia, so the efficacy, so both are causing the equal, but the dose requirement, morphine takes 10 milligram to reach this, but pethidine take 100 milligram to reach this. So both are having the equal efficacy, you can see. Now pethidine, this morphine and pethidine, morphine take 10 milligram, pethidine take 100 milligram to achieve the same thing, right? So very good, guys. So you can see the efficacy is same because the effect is equal, but the dose requirement is different. One is taking 10 milligram, one is taking 100 milligram to achieve this effect. So you can say that pethidine is less potent, or you can say morphine is more potent. So if you talk about the efficacy is similar, but if you talk about the potency, so you can see the left sided means less requirement of dose. So potency, morphine is 10 times more potent than the pethidine. Morphine is 10 times more potent than the pethidine. Same if you compare the fentanyl with the morphine, fentanyl is more potent. Fentanyl is 100 times more potent than morphine. So overall the potent, if you are talking, then it is fentanyl opioids. Morphine is more potent than pethidine, but not more than fentanyl, right? So this is again important concept. The next is enalapril and triamtrine combination is contraindicated. Why? So when the combination is contraindicated, you have to see the effect of these two drugs in the combination. Maybe the side effects are worsening, or maybe the effect is antagonized. So we have to see both aspects. Enalapril is angiotensin converting enzyme inhibitor. If you talk about the effect, it is causing vasodilation. If you talk about the effect, it is causing vasodilation, so can be used as antihypertensive. If you talk about the triamtrine, that is epithelial sodium channel blocker, it's a diuretic. Epithelial sodium channel blocker, it's a diuretic. So when we use the epithelial sodium channel blocker, what is the effect? It is causing diuresis. So it's a diuretic, right? So both the effect can be combined. Vasodilator plus diuretic, both effect can be combined to be used in patients who have the increased load in the arteries or in the blood vessels. So for hypertension and all, we can combine. But if you will see the other effect, it will cause the hyperkalemia. Triamtrine also cause the hyperkalemia because it is potassium sparing diuretic. So it's a potassium sparing diuretic, and because of that it will cause the hyperkalemia. Enalapril, that is angiotensin converting enzyme inhibitor, that is also causing hyperkalemia. So you can see both these drugs are causing hyperkalemia. That is why. So very good, guys. So because of the hyperkalemia, these drugs should not be combined, right? So that is again important. So even the spironolactone should not be given with this enalapril. But we can use the other diuretics, like we can use the loop diuretics, we can use the thiazides, because they are causing hypokalemia. So loop and thiazides can be combined. Very good. Next is nitrates are used in cyanide poisoning. Why nitrates are used in cyanide poisoning? So in cyanide poisoning, what happens? The hemoglobin converts to cyanohemoglobin. So there will be cyanide toxicity, cyanohemoglobin, that is having high oxygen carrying capacity. It does not leave the oxygen. Because of that there will be hypoxia, tissue level hypoxia and death. Right? Nitrates are converting the hemoglobin to methemoglobin. Nitrates are converting the hemoglobin to methemoglobin. Now when you give the nitrates, methemoglobin formation in cyanide poisoning, what will happen? It will combine. It will form the cyanomethemoglobin. It will form the cyanomethemoglobin. Cyanomethemoglobin, that is less dangerous than the cyanoglobin. After that, you can add the sodium thiosulfate. You can add sodium thiosulfate. You can add the sodium thiosulfate. It will combine with this cyanide and there will be formation of sodium thiocyanate. There will be formation of sodium thiocyanate and that will be excreted in urine. That will be excreted in urine, sodium thiocyanate. So we don't prefer nitrates, we are preferring the nitrites. We are preferring the nitrites like amyl nitrite, or sodium nitrite. Amyl nitrite used via inhalation, nebulization. Sodium nitrite used via IV route, intravenous. So these are preferred, not the nitrates, because these are amyl nitrite, sodium nitrite are very faster. But nowadays for cyanide poisoning, we have the cobalamin. So cobalamin injection is there, so that will form the cyanocobalamin. So that is the drug of choice for cyanide toxicity. But in sodium nitroprusside overdose, we use this because in sodium nitroprusside is used for emergency hypertension. So we have to control the hypertension also. You have to stop sodium nitroprusside. So you have to give the other antihypertensive. So then we can use the nitrates or nitrites. Right? So this is the reason, guys, we use in cyanide toxicity. Next is anabolic steroids have been banned in competitive sports. Why? Anabolic steroids like nandrolone, stanozolol, oxymetholone. These are some anabolic steroids. They have the high anabolic activity. They have the high anabolic activity. High anabolic activity. They have less androgenic activity. So androgenic actions are also there. Less androgenic activity. So high anabolic, less androgenic activity. Now nandrolone, stanozolol. Nandrolone is durabolin injection commonly used. Stanozolol, oxymetholone. So in competitive sports, sportsmen. Why sportsmen were using these drugs? So because of their high anabolic activity, it increases the stamina. It helps in muscle building. Helps in muscle building, stamina. But this androgenic nature, this androgenic nature, right, that is causing aggression. Because of androgenic activity, aggression. And because these are steroids, so because of androgen, there will be aggression. These are steroids also having the risk of liver toxicity, non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease. Right? So mostly what happens, these sportsmen, they are misusing these drugs. They take the more than recommended dose of these drugs, more than recommended dose. So that is why they are included in the dope test. So they are harmful if not used in recommended dose. So that's why they are included in the dope test, right? So many athletes have been debarred because of using these anabolic steroids, especially in Russia like country. This is very common. Then trihexyphenidyl, right? So in athletes, now it is, WADA, NADA, these agencies are testing all these drugs. So even the salbutamol is there, so many drugs are there, so misuse of these drugs is prohibited. Trihexyphenidyl, that is THP in short, which is also called as benhexol, used in drug-induced Parkinsonism. It is used in drug-induced Parkinsonism, not levodopa. We don't use levodopa, we use the THP. Why? Drug-induced Parkinsonism. Drug-induced Parkinsonism due to dopamine blocker, like antipsychotics, haloperidol-like drug, antipsychotics, like metoclopramide. These drugs are dopamine blockers. So you can see the dopamine receptor already blocked. And because of that, there is side effect, and that is extrapyramidal symptom. There is Parkinsonism. Extrapyramidal symptom or Parkinsonism. Now if you give the levodopa, what is levodopa? Levodopa is a dopamine precursor. Levodopa converts to dopamine. And where this dopamine act? Dopamine act on dopamine receptor. If the dopamine receptor is already blocked, it will not be effective. Right? We have to give the very high dose if you want to see the effect. We have to basically competitively inhibit this. What is THP? THP is anticholinergic. So remember, in Parkinsonism, either increase the dopamine or decrease the acetylcholine. This balance is very important. Dopamine and acetylcholine. Balance is very important. In Parkinsonism, the dopamine level is decreased. So either increase the dopamine or decrease the acetylcholine. So either dopaminergic or anticholinergic, both will be effective. Right? So that is why instead of using levodopa, we use the THP, benhexol like drugs. Right? Very good, guys. Then comes to next, tamoxifen, which is SCRM, selective estrogen receptor modulator. So tamoxifen, used in prevention of postmenopausal osteoporosis, not used in prevention of postmenopausal osteoporosis, but raloxifene is used. So we have the tamoxifen and raloxifene. If you talk about the breast, both are inhibiting the breast receptor, estrogen receptor. So both can be used for breast carcinoma. But tamoxifen approved for treatment as well as prophylaxis both. Raloxifene approved for prophylaxis. If you talk about the bones, both are having the agonistic effect in the bones. So both can inhibit the resorption of bones. Because of that, they are effective in preventing the this osteoporosis. They are effective in preventing the osteoporosis, so they can decrease the effect of osteoporosis. Both these drugs can decrease. But still we use only raloxifene, we don't use tamoxifen. The reason for that is the effect on the uterus. or the endometrium. In uterus, tamoxifen is having agonistic effect, raloxifene is having antagonistic effect. Right? So in bones, both are having good effect, but in uterus, they are having the opposite. Because of endometrial estrogen receptor agonistic effect, there is risk of endometrial carcinoma. There is risk of endometrial carcinoma. So risk of endometrial carcinoma is there. Raloxifene decrease the risk of endometrial carcinoma. It does not have the risk of endometrial carcinoma. That is the reason. The tamoxifen, and in postmenopausal, mainly the risk of endometrial uterine cancer is there. So that's why we don't use tamoxifen, we use the raloxifene. Very good, guys. Next, need of large dose of lidocaine to anesthetize the infected area. Why? Why the need of large dose of lidocaine? So lidocaine, it is the local anesthetic sodium channel blocker, local anesthetic as well as antiarrhythmic, used in digitalis induced ventricular arrhythmia. It is the drug of choice, lidocaine. In local anesthetic, it is amide group. Now, lidocaine is alkaline in nature. Lidocaine is alkaline in nature. The pK of this drug is around 8 to 9. So it is alkaline in nature. In the infected area or in the inflamed area, in the infected or inflamed area, what happens? Acidic pH is there. You will see the pH 2, 3. Acidic pH is there. Now you can see alkaline drug in acidic medium. Alkaline drug in acidic medium. What happens? More ionized, Henderson-Hasselbalch equation, less unionized. More ionized, less unionized. And which can cross the membrane? Only the unionized can easily cross the membrane, not the ionized. So because of more ionized, it less cross the membrane, and that's why the dose requirement will be higher. And because of that only it is slow. It is having the slow as well as the large dose is required. Right? So this is one of the important reason for the lidocaine used in the infected area. So Hima is asking, sir, what are the options after MD Pharmacology? So you can go in the industry, you can go in the teaching, you can go in the medical college teaching, right? In all these options, and you as well as you can practice. You are a doctor. All the options are there. Then beta adrenergic blockers, means beta blockers, should not be given alone for the treatment of pheochromocytoma. Why? In pheochromocytoma, that is a catecholamine secreting tumor. Mostly adrenaline. So noradrenaline secreting tumor could be there. In adrenaline secreting tumor, catecholamine, so raise BP. If suppose we use the beta blocker in adrenaline secreting tumor, so what happens due to adrenaline? In adrenaline secreting tumor, effect on the blood vessels. So what is the effect on the blood vessels? Adrenaline having the alpha and beta both action. So due to sudden release of this adrenaline in the blood, it will have the more alpha action because alpha is dominant. So alpha is powerful. So because of alpha there will be vasoconstriction. Alpha causing vasoconstriction. Beta effect is there, but alpha is dominant, but then it is metabolized and the level is decreasing, and because of that with the time only beta 2 action will be there, and that is causing vasodilation. So this is the biphasic response. Now if you use the beta blockers, you can see the unopposed alpha action will be there, and if you use the alpha blocker, unopposed beta action will be there. Alpha blocker can cause severe hypotension, and beta blocker can cause increased blood pressure, hypertension, right? Severe hypertension. So in this low BP, in alpha blocker low BP risk, in beta blocker high BP risk. So what is the ideal treatment? Ideally alpha blocker followed by beta blocker. Alpha blocker causing severe hypotension, that is called as Dale phenomenon, vasomotor reversal of Dale. And this beta blocker if you use, that is causing reversal of vasomotor reversal. So that's why we use the alpha blocker, there will be vasomotor reversal of Dale. Give the beta blocker, that can reverse the vasomotor reversal. So that is the reason that we should not use the alone. So guys, we have the plus subscription on Unacademy. You can access the best of Unacademy by using or by getting this subscription. So we have the daily live classes, we have the structured designed course by the specialist, we have the live test and quiz, we have the unlimited access to all these in one subscription, and the monthly subscriptions are there. We have the iconic subscription also, in that you can get the best of Unacademy as well as the prep ladder. So live course, batch course from the Unacademy, live test and quizzes from the Unacademy, as well as the video lecture and question bank 2.0 by the prep ladder and rapid revision course. For all these you can apply my code to get the 10% off on the subscription. Simply download the Unacademy app, learning app, open it, select the NEET PG plus, and then click on the get subscription. You can select either plus or iconic. You can select the month, then you can apply the code, you will get the 10% off. So I already shared my code Pharma UA. We also have the Dr. Dinesh, but Pharma UA is applied for special as well as plus classes both. So we have the target next 2022 batch from 21st of December to May 2021. This is the evening batch, December to May. The classes will be 3 to 5, 5:30 to 7:30 and 8 to 10 p.m. These are the educators which will who will take the classes. So concept wise coverage of all the subjects, discussion of high probability questions, coverage of all pattern of questions, and doubt clearing session of all the subjects. So simply download the Unacademy app and subscribe now and get the 1-year subscription only on 24,750. For that you can apply my code Pharma UA. We have the free NEET PG test series, so you can enjoy these test series also every day at 8 p.m. for 2021 batch, and for 2022 batch every day at the 9 p.m. and the description in description you can get the link also. So that is the best of Unacademy for you. So thank you guys, let's crack it. Bye bye.